Well, thank you so much for that introduction, and thank you for this invitation to allow me to speak about something that it's been on my mind for a long time about screening. Is screening misunderstood? Like you already said that, but I'm Guylène Thériault. I'm a family physician, and I do work in Quebec. So, is screening misunderstood? I think the answer is yes, but I kind of made it fuzzy a little bit because I think it depends who you talk to, and I think it depends also what aspects of screening you're talking about. But at the same time, I think it is yes, and maybe we should think about why. Why is it misunderstood? So I'm going to guide you to some of the thinking that I have on this topic along these slides. So potential conflicts of interest, you already said, I do receive honoraria for being a family medicine co-lead, for choosing Wisely Canada. I'm also receiving stipends when I do facilitate the Practicing Wisely workshop and when I give different conferences, and sometimes I do have expense reimbursement. As the co-chair of the Canadian Task Force, this is not a paid job, but I do receive some expense reimbursement. So the Canadian Task Force, for those who might not know, is the body in Canada that makes recommendations about prevention and screening for Canadians. I'm also on the board of Choosing Wisely Quebec and on the scientific committee of TOPIMIF, which actually is not the same, but similar to therapeutic initiatives in some ways, and provide resources in French. So what are we going to talk about? So we're going to spend a lot of time talking about why is that misunderstood, and reflect on some public messaging on screening and why these, might and induce the fact that we're not thinking of screening the way we probably should be. Then at the end, I'm going to describe certain steps, needed to elaborate screening recommendations, and I'm going to share with you a little tool we kind of use in Quebec when we're confronted by people asking about, guidelines and how we can have an idea of their value. So, why is all the fuss? I mean, it's simple. Screening is simple, isn't it? I mean, earlier is better. Screening saves lives. This is all common sense. And why did I put the basketball player there is that maybe you're aware, but the task force at the moment is updating its breast cancer screening guideline the breast cancer screening guideline. And I was interviewed by a journalist, and she told me, well, why does it take so much time? Isn't it like a slam dunk? It's screening is simple, So I'm going to get you to some of the thinking that you might have to do in order to better understand screening. But I always wondered why is it so ingrained? Why is it so deep rooted inside individuals, even physicians and the population, that screening is better and is good? And there's probably a lot of explanations. And if there are sociologists or psychologists here in the room, they might say that I have a very simple explanation. But this one at least resonated a little bit with me and might resonate with you. So in the last, 200 years or so, the lifespan hasn't changed. It's around 100 years. But what did increase is the life expectancy. And why did that increase? For many, many reasons. I mean, there's all the public health initiatives, the way we eat and drink and, the exercise and so forth. But there was at some point the discovery of, we could make a diagnostic. People were presenting with symptoms, and then we could find that there was a bacteria, that were giving them their problem, and then give them an antibiotics, and all was good. And when we got to handle in the infectious disease, then what was left? Well, was chronic diseases. And we tried to apply the same recipe, you find what is wrong, you give something, and then all is good, but all was not good. So people started to think and say, well, maybe if we take it earlier, that seems like a sensible idea. And this, how I think part of it started, of thinking that screening and finding it early is always a good thing. But there's more than the eyes can see. So if you're like my friend and you don't see that there's a problem there, maybe, it's my kind of metaphor to let you know that, when you talk about screening, it seems very straightforward, but there is much more to uncover to really get a grasp of screening. So if you are like my friend who you don't see it, just look between the two men and you'll see that something is not quite right there. So in anything we do in medicine, screening, but also like treatment and everything, there are benefits and harms. And the way we are trained, or the way our mind is made, is that we have a tendency, not just our patients, but us too, to overestimate the benefit and underestimate the harms. And in screening, it's particularly important because most of the time, when screening does work, the benefit and harms are more like in equipoise. They're like kind of similar in size. So you really have to know, what are the benefits and what are the harms to make a decision. So I'll start by showing you some, traps that I think we can fall into when we are thinking about screening. And the first one is more general, and it's numeracy. So we are not good at numeracy, but sometimes we can understand it quickly, but not everybody. So I really smiled when I saw that. In the 1980s, A&W tried to compete with the McDonald's quarter pounder by selling a third pound burger at low cost. But it didn't work. It failed because most consumers thought that the quarter pound was bigger. And sometimes there are other things that are much more complicated. At least for me, it was when I read this about, 2 medium pizza, it's probably smaller than a large pizza, but then it depends on the size of the pizza. And I was all mixed up, about the radius and the diameters and so forth. So sometimes it is complicated, but in screening and in observation, in intervention, the math that we're asking you to do is not really very complicated. What we're asking people to grasp is the difference between a relative effect and an absolute effect. So let's say today I give you a 50% rebate. Probably a part of you at least are smiling and say, well, that's good. But at the same time, a good proportion of you said, well, it depends on what. And if I give you a rebate on the really nice car over there or on bubble gums, then you won't save the same amount of money. So it's the same thing when you think about diseases. So for example, and I'm making this up, if I had a disease that would kill 40 individuals out of 100, and I would have an effect of 50% less, then I would get down to 20 out of 100, and I would have 20 out of 100 as a benefit. There's no screening that have a benefit huge like that, but I'm just giving examples. But if on the other end you had, 4 in a million people that died, 50% would represent 2 in a million. So it's quite different. So it's quite important that when you're presented with relative effect, to ask about the absolute effect. And that's why sometimes in screening, you need, in other areas too, but you need those tools to have the data in absolute numbers and be able to share them. So this is the tool of the Canadian Task Force on Prostate Cancer Screening. Prostate cancer screening is not recommended, but from time to time, there's somebody, a man that comes in and has questions, and you could share some information with him. So you could see here there's 1,000 men. If you screen them for 13 years, well, the one at the bottom, the yellow one, is the man that will not die of prostate cancer because he was screened. There's 5 that would die anyway. The blue ones represent false alarms, and the green ones represents overdiagnosis. So true cancer diagnostic, but if they would not have been screened, they would not have had any symptoms or any problems from this cancer. So this is an absolute term, but I could have told you that it's 15% less death, which is the same, but it's much more transparent and absolute effect. So ask for that. And if you want to read a little bit more, I put one reference there, but there's a lot of other references you can look at. So that was my first message. But what I wanted to talk about also was about correlation. And probably many of you know that correlation is not causation. But still, it's hard sometimes to think about that when we think about screening. So here, so did you know that, there's a relation between the ice cream sales and shark attacks? Yeah, they both go up in the summer. This is a correlation. This is not a causation. Actually, it's because it's the summer and it's hot and people would like to have, something refreshing, or they would like to go and swim, So the temperature, the outside temperature, is a confounding factor. And that's what we have to make sure when we look at intervention and their outcomes, that we can put aside these confounding factors. And one of the best way is to build randomized control trials. So let's say here the exposure and screening and the outcome is decreased mortality. In a randomized trial, you would have 2 groups that are similar at the beginning. So you could feel, if it's well done, pretty confident that it's the screening that affects the outcome. But if you're not randomized, then you have these questions about confounders. And 2 things that I wanted to highlight here is that, sometimes you could have what we call the healthy screener effect. So people that, are more healthy or more enthusiastic about their health might go more for screening. And the other thing that is something that we're reflecting a lot now is that treatments are getting way better. So if treatments are getting better, what is the place of screening in the reduced mortality, for example? Is that less, because treatments are better? So this is all things that you have to be aware and think about. So beware of confounding factors. Now, the thing we hear often is that, the incidence is increasing, so we have to screen more. Well, actually, if the incidence is increasing, maybe if you screen, you will be able to help some people. But when you screen more, you always get a mix. You'll get people that are, yes, they won't have the outcome, like they won't die, for example. Some maybe 0. Sometimes some screening do not give benefit, but some might. But you'll have people that, would die anyway, or people that would not die anyway, or people that are overdiagnosed. So it's a mix. So it's not because the incidence is increasing that we should simply say that it's a slam dunk. You have to screen more. You have to think and find evidence to prove that you're doing more benefit than harms. So increased incidence is not synonymous with increased benefit from screening. So one recent example about this increased incidence that I've seen, I'm going to show you because, it's easy to get fooled. And if you look quickly, you might get fooled. I'm going to start with an example that has nothing to do with screening. Cola, soda, which one is more popular? Look quickly. Which one do you think is more popular, the Yummy Cola or the Trail Soda? Well, if you look quickly, you say, well, the Trail Soda looks like it's preferred. But then if you look more closely, look at the y-axis, you're going to see that there's a trap there. Look at the 50 to 100% for the Yummy-Cola and 0 to 30% for the Trill Soda. So in fact, the Yummy-Cola is more popular. And you say, well, what's the link with, screening? Well, this example is quite telling. So that was published last year, where, there was this argument that, there is an increase in early onset colorectal cancer and that we should screen more. And you could see in 0049 on the left, you could see the incidence is going up. And the 50-64, you could see, well, it's going down and then it kind of plateaus. And in the 65 plus, well, it's going down. But did you look at the y-axis? So for the 049, it goes from 0 to 10, and 50-64, 0 to 120, and more than 65, 0 to 450. So that's something that you have to beware. And some very intelligent people did plot everything back in the same figure. But before I go to this, I just want to note that probably some of you said, well, she just said that we should talk in absolute effect, and she's showing us a relative effect, because that's what was, the main message of this article. But I'm going to show you what it means in absolute term. So in absolute term, it was an increase of 5 over 100,000 people. And if you plot them on the same axis, it's getting pretty hard to see that it's increasing. Not to say that this is not something we should, try to do something about, but maybe screening is not the answer. At least we should strive to ensure that screening might be more helpful than harmful. And at the moment, I looked for you, the last review of 2021, there was only 3 studies that included adults younger than 50, but there was no data provided by age. So it's a bit hard to say, what is the relation between benefit and harms that we could have if we would screen people younger than 50. So beware of the y-axis. But, I don't want to have a disease. I don't want to have a cancer. I don't want to have diabetes. I don't want to have all these things, So maybe I should just look more for them, If I look closely enough and if I look enough, I'm going to find more disease. And that's one example, and it comes from breast cancer screening. And this is an example, it was published in 2021, but there's other publications similar to that. So if you screen for breast cancer with mammography, you find a certain number of cancer. And if you add modalities like ultrasound, tomosynthesis, MRI, you find more and more cancer. So you can increase the cancer detection rate. But at this point, you should say, well, okay, interesting. But do we have any data that focuses on patient-oriented outcome? These new diseases that I found, am I doing more benefit than harms? And there's no, to my knowledge, studies that focus on these outcomes like mortality, quality of life, decreased advanced cancers and so forth. So finding more cancer, it's not something that's a slam dunk that, we're going to create more benefit. Here it is the classical, at the top, look at the top first, and it's a classical curve, of overdiagnosis. This is for prostate cancer. So you see when it was popular, the incidence, went up and then stayed up for a while. Now it's slowly decreasing because, screening is less than before. You see that the mortality is decreasing, even if the incidence is decreasing. So it's not the screening here that is influencing the mortality. It's most likely the treatments that are getting better. Just because I'm talking about incidence and mortality, just want to show you that, in colon cancer, it's a bit of a different way of thinking about it, because we do find a lot of pre-cancers and we take them away. So what happens is actually we're decreasing the incidence. And by decreasing the incidence, we are decreasing death. So it's just different than when you think about breast, prostate, and lung. It's more like the figure on top, and colon is a bit different in its reasoning. But the message really is that just simply finding more cancer is not a synonym with increased benefits from screening. You have to prove it. You have to make sure you're doing more benefit than harms. And then lastly, on these, misleading statistics, this is the one that I think I see the most often. So if you look at the top, it's about lung cancers. And, if you're diagnosed at stage 1, you have 53% chance of being, alive 5 years later. And if you're diagnosed at stage 4, it's 4%. So early detection saves lives, right? It's compelling. I mean, even if I know this is misleading, it's compelling. And this is what you see messaged, all over the place. But I'm going to show you why 5-year survival is not the right metric to use in cancer screening or in screening in general. And then I just added the one on the bottom just because, it shows the same thing. Diagnosed early, you have more people surviving 5 years, and diagnosed late, you have less. But this is for a cancer that there's not even a screening test. This is for pancreatic cancer. So you can put anything really out there. So trying to explain that why 5-year survival is not the good metric. So these lines are all individuals. So at the start of the line, they get their diagnostic, and at the end of the line, they die. And you see how long they live for, and they don't have their diagnostic at the same time. So if you were to calculate, you would say, well, 40% of those, survive 5 years. But then if you screen them, you see the little red that appeared on the bottom. If you screen them all, you will find the cancers before. Because if you don't, the cancers or the disease, but if you don't, then your screening is not working. It has to find the disease earlier so you have the potential to intervene. But then you would say, well, there's 70% of those that live 5 years. So this is not a metric we can use because of this, which is actually called the lead time bias. The fact that, in screening, my survival time will be longer just by the fact that I find the problem earlier. What I really want to look at is the black, round black at the end. If those patients, die less in the screen group, not the length of time they survive. This is misleading. Another reason why 5-year survival is misleading is that if you look at the bottom, these diseases that are indolent, very slow to progress, have more chance to get picked up by screening. So thus, it increases the 5-year survival also. So 5-year survival statistics is not a good metric in its screening. Okay, so what do we see out there? Well, we see many things. And this is something that I see time and time again, mixing prevention and early detection. In breast cancer, this is totally two different things. Prevention would be, probably drinking less alcohol and exercising in order maybe to not get a breast cancer, but early detection, you already have it. So you cannot screen for prevention, at least not in breast cancer, prostate cancer, and lung cancer. You can make an argument that in, colon cancer, if you screen and you take enough of the precancerous lesions, you might prevent some lesions. Yes, but this is not the way it's presented to the public. Yeah, that billboard on the side of the road saved my life. Maybe, maybe not. There's a mix. When you screen people, you will have people, if it is a proven screening that works, you will have some people that will benefit, but you will have some people for which the outcome is not changed, and some people that are overdiagnosed. So it's not because you screen and you get a diagnostic that your outcome is changed for the better. There are a proportion of those, but there are a proportion of other outcomes also. But, it's so easy to sell, because of all the things that I described before. And I've yet to see a publicity that would tell me more than just, trying to convince me to go and get screened, tell me some factual information and just tell me maybe that there are pros, but there are cons also to screening. But that's not the way it goes. And even cancers, screening that have no proven benefit, they're trying to sell that to people. And, she's young, she's beautiful, it only takes 2 minutes, why not? Why not get your screening? Well, when you know that it's not changing any outcomes, then yes, why? It's more why than why not? So screening saves lives, don't be the one missing out. These rhetoric is everywhere. You can find it for cancers which have been proven to have some benefit, like, for example, breast cancer screening, but you find it also for all kinds of sorts of disease or cancers with no proven benefit from screening. So this is pervasive, and I think it makes it difficult, for people to really understand what screening is all about. But maybe there's a glimpse of hope. Anyway, I tried to see a glimpse of hope there. About 15 years ago, this ad was, everywhere, but not everywhere here in Canada, but I think it was in UK. If you haven't had a mammogram, you need more than your breast exam. And maybe it was in the US, I'm not sure. But then I saw this and I said, well, okay. I didn't dig too much deeper because I wanted still to have some hope, because the message was talk to your family doctor about getting checked. And I thought maybe it's talk to your family doctor about the pros and cons of screening. Anyway, I'm trying to be hopeful. Okay. So when I told you all of this, but how do we go about and develop some recommendations? Because that was one of the objectives. So first of all, when we're confronted with doing guidelines and making recommendations, we have to make sure that we're asking questions that are meaningful. And meaningful, most of the time, means to choose outcome that matters to patients. So, patients would like to die less, maybe to be less hospitalized, a less harsh treatment, things like that, quality of life, things that matter. So you have to really think of your questions to make sure that you answer questions that are relevant to your patient. So that's the first thing that you do. And then you look everywhere. You look everywhere to find the answers. And you look first, at least in the questions that we do ask about screening, we look first at randomized controlled trial for the reason that I explained before, to try to ensure that there's not too much confounding in the relation between the screening and the outcome. Sometimes we don't find, good quality RCT, so we have to rely on other kind of studies. But then, we're less sure of the relation between the two. So we look everywhere. The next slide is a bit busy, but the message of the next slide is to say that after you have gathered all your information, you need to have a panel that is not conflicted, because it does make a difference. And this was something that I think was very telling. You have two panels here, 88 and 89, two panels that make guidelines about the same thing, but at different times. And in the panel 89, there were much less conflicted individuals. I think, they really lowered it to the minimum. I think there was none, I'm not sure, and you could see that, there was much less strong recommendations and much less evidence that was judged at high quality. So being not conflicted does make a difference in the output of your recommendation. So that's it. You identify the problem, you formulate your question, make sure you answer patients' relevant outcomes, you gather information about the desirable, undesirable effect, the certainty of the evidence, you balance all of this, thinking about equity, feasibility, and then you come up with a recommendation. Seems simple, but it's not that simple, but that's the process. And this is the last part, a very quick look at, a little tool that we use in Quebec that has become very helpful for us. In the Practicing Wisely workshop, we talk about cholesterol. And then we talk about the simplified lipid guidelines. And we had this question all the time. Yeah, well, there's another guideline. So we say, okay, how can we convey that there's a difference between those two guidelines? So Pascal Brault, which is a colleague of mine, was looking at the different tools, came up with the G-Trust, and then says, well, there are 3 questions that seems to me very important, and we now call that the mini G-Trust. So the 3 questions is this relevant? Does that apply to my practice? What about interpretation? So it's all a judgment about conflict of interest. So very, linked to what I just said, a few slides before. And is there a factual basis of the recommendation? So what we mean by that, is there a systematic review? Can you access, how they did that? Is that of good quality? Could be great, could be something else. And I just want to know that when we talk about relevance, we added here, a bit more information, but the patient-oriented benefits are of importance. So we do apply this to the cholesterol guidelines, comparing the simplified lipid guidelines to the CCS guidelines. But I did the exercise this week to compare 2 other guidelines. The one from the Canadian Task Force on Screening to Prevent Fragility Fractures, and the one from Osteoporosis Canada that was just published a few days ago. So just the way I expressed it, our guideline, the task force guideline is not about osteoporosis. It's about, screening to prevent fragility fracture, while Osteoporosis Canada talks about osteoporosis, even in primary prevention. So relevance, well, we do have a tool with absolute values. From what I could gather, I did not see any outcomes specified in absolute risk reduction, except if you go deep in the evidence to decision table framework at the end, and this is an appendix. We considered time needed to treat and overdiagnosis, which was not considered in the guideline just published this week, but overtreatment was mentioned at least twice in the guideline. As for conflict of interest, well, that was very happy to see that there was much less conflict of interest than there were in 2010. So making that probably more reliable. Systematic review, we do publish a systematic review with every one of our recommendations. I couldn't find the one for Osteoporosis Canada, but I could find their evidence to decision framework where there was a lot of information. And actually, I was pleased to see that, regarding the benefits, where we have almost exactly the same benefits. Where we differ a lot is on the values and preferences of patients, where we feel it's much less and much more variable than they feel it is. So anyway, I will conclude. So if screening is misunderstood, which I think it is, what can we do about it? I think we need information about screening that is transparent. And what I mean by that is that it has to be about outcomes that matter in absolute numbers. It has to be based on the right evidence, and it should be made by panels with no conflict of interest. And I would underline another few key points, to go back to what I said through the presentation. Earlier or more detection of disease is not a synonym with better health outcomes. It might be, but we need to know what's the balance between the benefit and harms, because screening has potential benefits and harms. And we should strive to avoid misleading statistics, because if not, screening will still continue to be misunderstood. And if we want it to be better understood, we have to talk in a very transparent way. Thank you. That's what I had to say.
Guylène, thank you so much. What a insightful and thought-provoking presentation. Um, I have so many questions, and there's some great questions and comments in the chat. Let me share the first question. Do you feel that screening guidelines tend to become functional mandates? If so, is that exacerbated when providers are judged on adherence to guidelines?
Yeah, I live in a province where we don't have these mandated things to do in our practice. But I know that in the province just beside me in Ontario was the case until recently. Yes, I think, from what I know about screening, most screening, as they have a tight balance between benefit and harms, and I don't think we should mandate anything. We should have discussions. And I don't have the data, but I think yes, it could push for more screening than informed patients might really want.
Okay, thank you. A comment, public expectation is that screening is to catch every single case, no matter the cost and difficulty, which I think is highlighted by everything you said today. Another question, why does screening differ in provinces? For example, PSA screening is not covered in BC, but covered in other provinces. Why, if the evidence is the same, why are people making disparate decisions?
Yeah, this is I don't know if I have the answer to that. I mean, we're trying at the task force at least to have discussions with our partners of different provinces to try to share, our evidence and how we reflected upon the evidence. But then we're not the one making the decisions. And like I highlighted, Asoposis Canada recent guideline and ours, we have the same trials, the same expected benefits, but then our recommendations are different because I think we don't value the same thing the same way.
So on a related note, if I could ask, what is there to gain from governments promoting things like breast cancer screening in a way that's so sort of coercive? Like you need to get your head checked. I could understand if it was a for-profit way to sell more screening, and so they're conflicted. But what you're suggesting is that screening that doesn't lead to a net benefit to society is probably costing us more than it's saving us. So it just seems there's a disconnect there.
I think I mean these are very hard questions, but I think they are not only in screening, in many things. There are a lot of lobby, that talk with government, and a lot of misunderstanding of what screening is. So you can imagine if people in government think that finding more and more and more cancers is only beneficial, then it's like a vicious circle.
Sure. Okay, that makes sense. The next question, to what degree should we be talking about the limited resources of the public healthcare system, materials, human labor, energy, etc., when considering screening guidelines?
Yeah, I think, from my work at Choosing Wisely, I think I reflect a lot on what is low value care, what is high value care. And I think, there's so much low value care out there that we have to think of how we're using our resources to the better good of Canadians. We have limited resources. And I think that's for screening, at least many, many screenings, and for having had many, many discussions with patients. When you share the evidence, some will want to be screened, some will not want to be screened, and that's fine. This is two decisions we should respect. So I think just to mandate a screening, like for breast cancer, but just to mandate it is maybe not the answer to for using our resources more, efficiently.
Sure. Okay. Yeah, I like the idea because I've encountered family members that have come to me and said, my neighbor had this screening test and they found something, and that person is still alive, thankful because they received treatment early. Why are you so yeah, and this relates to the next question. Starts with a comment. Human nature tends to do whatever it takes versus being treated as a faceless number. I find it challenging treating my individual patients with cold hard data while making them feel that I care about them. Are there not two sides of screening, the art and the science? Should we be individualizing screening? And I think that's what you're getting at with a shared decision about whether you choose or value screening or not.
Yeah, I think shared decision making, it's not a cold exercise. It's a very relational exercise, actually. Yes, there are numbers, but there's much more to just sharing the numbers. But one thing he said in his I forgot the last part of the question. I was looking at it, but
Oh, should we individualize screening?
yeah, so that's something that, stay tuned. Maybe it's something that if we can get more data on this, that would increase the value of the screening we're doing. Because if you start with a population that is more at risk, maybe you could have more benefit, and then the balance shifts a little bit.
Mm-hmm. And another related comment, someone's saying, I have trouble putting it into words, but I continue to be worried about that we're spending so much time and resources in physician manpower on screening or doing tests just in case. We don't have the space in the system to quickly treat people who are actually ill, yet we're spending all this time on screening. So that, I think it supports what you're saying.
I just
This,
say that when I present practicing wisely, I always say, what are the three words that cost the most to the health system? And I think it's just in case.
just in case,
Yeah.
Funny but sad at the same time. Another interesting question. I wonder if we need to do a better job in medical schools, and I would add pharmacy schools and nursing schools with this educational messaging. I had conversations in the past year with a hepatologist and a rheumatologist who were patients about breast cancer screening, and they clearly thought I was nuts when suggesting breast cancer screening was not as effective as the public messaging leads the patients to believe. So what's your sense of how this is being taught in universities in healthcare disciplines?
Okay, well, my sense is that it's actually very poorly taught, or it's not taught. It depends on the university, but where I work, it's practically not taught, at least in the pre-graduate school and even in residency. So I don't have, the number, but it's far and few between. And actually, I like this comment because, at the beginning you said I had a master's in education. I'm doing my doctorate in education to try to answer this, how we can do better to teaching from the onset of medical school or pharmacy school about these topics.
Mm. Yeah, it brings to mind an issue that has always troubled me but I find fascinating to think about is the unintended consequences of screening. So never mind does it capture more cancers or whatever you're trying to look for, but does that lead to the net public health improvement? But there's also a downside to screening. So if you detect incidental cancers that wouldn't have manifested as problems, but you're exposing people to more tests and treatments, the net public health effect could be negative overall, right? So that should be taught. I'd be interested to hear about your work in your doctorate when you're ready.
It's ongoing.
So another question I think we've sort of talked to, but doesn't cost have to enter into the question? Given that we do not have unlimited resources, don't we need to look at the financial benefits versus harms as well? So just like in many cases for medications, the cost effectiveness research that comes out alongside to help governments or funders make decisions, are those types of cost effective studies done for screening?
I guess, yes, there are some, but it's not something that we'll look at it when we do the full, evidence before we make recommendations. That's something that we will do a systematic review on. Now, we sometimes use modeling, and that can inform us on cost effectiveness, but want to say something about costs. So we see cost as something, it's monetary, it's dollars, but there are other kinds of costs. The cost of being worried, the cost of having to drive for all these tests, the cost of, maybe quality of life, is affected. So it could be affected in the right way or in the bad way. So, there are all these costs, and most of all, the opportunity cost. The fact that if we're doing more tests that have low value, we are missing time and resources to do tests with higher value.
Yeah, it's true. We often forget about those so-called soft costs that are as important or maybe more important, but definitely part of the equation. Just a comment here from a friend of ours who recommends a great book about misconceptions in healthcare called Less Medicine, More Health by Dr. H. Gilbert Welch. So if you're interested in reading after this, that looks like a good read. I'll have to pick that up. There are so many questions. We won't get a chance to go through them all, but I'm going to do some rapid fire ones. So let's see. Any recommendations for how we should educate the public or manage public expectation about the value of population screening?
Well, continue to do presentation, continue to say yes when journalists, calls and wants more information and give the same message that, there are, benefits and harms to screening. I don't have a magic wand. I mean, this is not something you undo overnight. But if you're not teaching about it, if you're not talking about it, then, nothing will change, I guess.
So I'm not a clinician, but as I mentioned, family have come to me and friends and said, my neighbor, they found something, treated better. What kind of phrases or words do you use to disentangle that web of information they have when you deal with your patients?
Yeah, well, it depends. My patients I've known for many years, so we have a different relationship than I would have with my neighbor. I don't think I would go into a lot of explanation with my neighbor, but with my patients, I would go back to what's important for them, and then try to give them a sense of the relation between the benefits and harms. It's always coming back to that. But then some patients, presented with the same evidence. I said that before, but some will want screening and some will not want screening, and that's perfect.
Sure.
That's perfect with me.
Yeah, it's a good decision. Yeah, you're right. Here's a lovely comment in terms of if you're going to make something mandatory, someone's suggesting making this talk mandatory in all medical schools. So, and I would agree. Okay, here's an interesting question. This comes up a lot at Therapeutics Initiative conferences, but it relates specifically to your talk. How does one avoid medical legal liability and college complaints when refusing or trying to talk to patients out of screening? Specifically, the influence of medical practice in the US on demand testing. And I'm anticipating that you might say we shouldn't be trying to convince people not to screen or to screen. What are your thoughts on that?
Yeah, I think you read me right. So, yes, I mean, the thing is, sometimes people think shared decision making is an exercise in convincing. It's not. It's really a shared decision. But the medical legal aspects comes up all the time when we teach about that. And, at least in Canada, I know the US might be different, but in Canada, there's not that many how would I phrase it another way? In Canada, the best way to protect yourself from liability is to be open and have discussions and listen to your patients. So if you have these discussions, you're probably much less liable than if you just said no or yes, to a test. And when you say yes to many tests, and I'm going wider than screening, then you'll have a lot in your inbox, and then you might be more liable because then you have to take, actions to all of these tests. So if you choose the tests that are of high value, you'll probably have more time to really take them into account in your practice.
Oh, fantastic answer. That's great. So I'll finish off with one more question, and I apologize to all the people that submitted questions that I didn't get to, but this one is great. With many different screening options available and the time-intensive nature of shared decision-making, do you have any tips on how to do this efficiently in primary care? Like, is there a resource where someone said, these are the high-value ones, worry about those, these are the low-value ones? Can you recommend something?
The task force is a resource, I think. about screening. There's actually a Cochrane review on this, and they measured how long it takes to do shared decision making, and they measured it at 2.5 minutes. So it's not that long.
Mhm.
And it's like riding a bike. The first time it's gonna be hard. Maybe you're gonna be mixed up. But
Sure.
then, when you integrate that into practice, it's not that long. And if you take away some of the things that you do and might not be of high value, you likely have the time to have these kinds of conversations. We did something for the fragility factor one. We calculated the time needed to implement the guideline
Hmm.
and compared it to Osteoporosis Canada 2010, because the 2023 was not available. And
Hmm.
actually, even if there was shared decision making, it took less time to implement.
Amazing. Uh, Fantastic. Again, I could talk to you all day and sure, and we'd have enough questions to fill up the day, maybe more than a day. Thank you so much for a wonderful talk.